Ladies and gentlemen, as you see from this slide, an ambition of the World Federation of Hemophilia is to produce hemophilia guidelines for all. And you know that in 2020, the WFH published guidelines for the management of hemophilia. These guidelines are the third edition of WFH Guidelines of Hemophilia. Here you can see the title page of WFH Guidelines for the Management of Hemophilia, third edition, with the list of all authors. Today, we will focus on chapter 9 of these guidelines, entitled Specific Management Issues. My name is Jerzy Windyga. I am a hematologist, and I work at the Institute of Hematology and Transfusion Medicine in Warsaw, Poland. These are my disclosures. Here you see the title page of our chapter, chapter number 9, and here you see the list of all authors. So the authors of this chapter are Jerry Dolan, Kate Kehir, Johnny Malangu, Richa Mohan, Margaret Rani, Abdelaziz Al-Sharif, Lisa Begley, Satyanarayan, Glenn Pierce, and Alok Srivastava. And here you can see the list of topics that have been discussed in chapter 9. This is a really big chapter. As you see, the list is pretty long. And of course, there is no time during this presentation to discuss in details every topic. So I decided to select some of them and to spend more time on discussion on carriers, sexuality, psychosocial issues, comorbidities, and medical issues associated with aging. As you see from this slide, our group developed a lot of recommendations. As I mentioned before, the chapter is really big, and therefore I would recommend to familiarize with the whole chapter and to read the whole chapter. So let me start from carriers. Severe forms of hemophilia typically affect males. Females have been designated as carriers, and most often carriers do not show symptoms of bleeding tendency. However, a proportion of carriers have low factor 8 or factor 9, which can result in mild, but sometimes moderate or even severe hemophilia. Of course, symptomatic females should be designated as having hemophilia of a specified severity, like males with hemophilia. Carriers who exhibit a greater bleeding tendency than would be predicted by the factor level, as in males, may have a second coagulation defect, and we should think, for instance, about von Willebrand disease or congenital platelet defects, because those disorders are relatively common. We believe, and this is our recommendation, that carriers should be registered in hemophilia treatment centers. And carriers with low factor levels should be treated the same way as males with hemophilia, which is pretty obvious. The next recommendation on carriers is that all potential and obligate carriers of hemophilia should have their factor 8 or 9 levels measured to establish their baseline levels. And this is particularly important prior to major procedures, surgery, and of course, pregnancy. The most common manifestations among symptomatic carriers include menorrhagia, dysmenorrhea, postpartum hemorrhage, perimenopausal bleeding, but also abnormal bleeding alone, of course, bleeding following trauma or after medical interventions like dental extractions or major surgery. It should be stressed that hormonal therapy may be very useful in managing heavy menstrual bleeding in carriers of hemophilia, and we may use oral, subcutaneous, or transdermal formulations containing estrogen, progesterone, or progestin the levonorgestrel intrauterine device, and also oral antifibrinolytics. The next recommendation with respect to carriers is on the pregnancy and prenatal planning. This is a very important aspect of this section. So, pregnant carriers of hemophilia should have their factor 8 or factor 9 levels assayed in the 3rd trimester of pregnancy to assess their bleeding risk during delivery and the postpartum period. It should be stressed that during pregnancy, factor 8 levels can increase significantly in carriers and may completely normalize in the later stages. Levels of factor 9, however, do not usually change significantly during the pregnancy. However, it should be stressed that even with factor levels above 50 units per deciliter in the 3rd trimester, carriers may experience abnormal bleeding during childbirth. What about labor and delivery? So first, I would like to stress that regional block anesthesia or epidural anesthesia in carriers of hemophilia is not contraindicated, but the coagulation screen should be normal, and of course the relevant factor, so factor 8 or factor 9, should be above 50% of activity or 50 units per deciliter, or we should use prophylactic treatment, most often replacement therapy, to raise the factor deficient clotting factor activity above 50 units per deciliter. So of course, factor replacement therapy can be used. In theory, also desmopressin can be used in patients with, in carriers with hemophilia, mild hemophilia A. We should maintain the levels above 50 units per deciliter for labor and delivery, and maintained in the normal range for at least 3 days after vaginal delivery and at least 5 days after cesarean delivery. Delivery of infants known or suspected to have hemophilia must be atraumatic to avoid any bleeding complications in child. Forceps and vacuum extraction vaginal delivery, as well as invasive procedures to the fetus, should be avoided. So our 2 recommendations with respect to childbirth and delivery: carriers of hemophilia should deliver in hospital. This is very important because in hospital, the specialists, the hematologists, the obstetricians are available, and the whole process should be supervised by a team of hematologists and, of course, obstetricians. And I'd like to repeat again, no instrumental delivery. So we should avoid any trauma and injury to child. What about postpartum care? Factor 8 and von Willebrand factor levels fall off fairly rapidly after delivery, usually returning to baseline levels within a couple of days, 7 to 10 days, but sometimes even earlier. Monitoring factor levels post-delivery is important, as carriers are at increased risk of primary and secondary postpartum hemorrhage that in some cases can be very severe and life-threatening. If postpartum hemorrhage occurs, the treatments are, of course, factor replacement therapy, but also antifibrinolytics and hormonal therapy. In fact, prophylactic hormonal therapy may be started immediately after delivery and continued for 1 month in selected carriers deemed to be at higher risk of bleeding. Delayed bleeding up to 35 days postpartum is possible and was reported in various papers. So we should keep in mind carriers can suffer postpartum hemorrhage. To illustrate the carrier care during delivery and during postpartum period, I'd like to show you this case study, very brief one. 28-year-old asymptomatic hemophilia A carrier with baseline factor 8 of 31 units per deciliter or 31% of activity presents to Hemophilia Treatment Center in 3rd trimester of her first pregnancy, male fetus, to obtain hematologist's opinion on hemostatic management of delivery. Her current factor VIII activity was checked. It was 132 units per deciliter. Pregnancy course was uneventful, and no concomitant disorders were reported. It was recommended to avoid instrumental delivery. Epidural anesthesia permitted because factor VIII was above 50 units per deciliter. Normal vaginal delivery was chosen by the patient and obstetrician, yet it was suggested that in case of problems during delivery, early recourse to cesarean section should be considered. She had an epidural injection with no complications, without any need for factor infusion, and underwent an uncomplicated vaginal delivery of an unaffected boy at 39 weeks, with spontaneous delivery of her placenta. Her factor level was 112% on day 1 postpartum. However, on day 3 postpartum, she reported light lochia, so bleeding, vaginal bleeding. Her factor VIII activity was at that time 53 units per deciliter, so very close to the baseline level. Gynecological examination was normal. That is very important for this case, because that means that the reason for lochia, light lochia, could be the level of factor VIII, which is in theory within normal range. On the other hand, it is at lower end of normal range. So it was decided to start factor VIII replacement therapy, and the target factor VIII target level was around 100 units per deciliter, and the effect, the outcome of this therapy was very good. Prophylaxis with factor VIII concentrate, and the infusions were performed every other day, was used for 10 days with full recovery. So this case illustrates this situation when, despite normal factor VIII activity, the patient developed some relatively light, mild bleeding complication following delivery, and with replacement therapy, she achieved full recovery. Of course, another very important topic related to delivery by carrier of hemophilia is newborn testing. And in the recommendation 929, or this recommendation states that male babies born to known or potential carriers of hemophilia should have cord blood testing of activated partial thromboplastin time, and ideally, of course, of factor levels. However, I'd like to comment on that because there is difference between factor VIII and factor IX, or child with factor VIII deficiency or factor IX deficiency. Normally, in newborn and preterm infants without hemophilia, factor VIII levels at birth are within the normal adult range or even mildly increased. Therefore, if we check factor VIII plasma activity in infant and we see very low levels, in fact, the diagnosis of hemophilia A is highly probable. However, factor IX levels at birth are significantly lower than normal in newborns without hemophilia, and even more so in preterm infants. So if we see very low factor IX levels, but more than, let's say, 1%, then of course the diagnosis of hemophilia B is uncertain, and we should retest the child about 3-6 months later to make sure whether the young patient suffers from hemophilia B or not. I would like to end up the discussion on the carrier section with management of miscarriage. Surgical management of spontaneous abortion is preferred in patients with a pre-existing hemostatic abnormality. Of course, adequate obstetric management is required, but carriers require also appropriate hemostatic management. And as always, hemostatic management consists of replacement of the deficient clotting factor or other treatment modalities in accordance with protocols for the management of bleeding complications in patients with hemophilia. So we move from carriers to sexuality. This is much shorter section in our chapter. Nevertheless, I'd like to dedicate or spend a couple of minutes or moments on this chapter. So this is very important, and important for our patient complication of hemophilia. People with hemophilia report relatively frequently problems with their sexual life. They join this problem with, for instance, joint stiffness or joint pain from sexual activity. They also report that they don't have adequate information regarding sexual activity from hemophilia treatment centers. Of course, in some cases, pharmacotherapy may be helpful. I would like also to mention hematospermia, defined as the macroscopic presence of blood in the semen, because this is not an uncommon problem in people with hemophilia, particularly in severe hemophilia, and may cause considerable anxiety in some individuals and their partners. We produced 2 recommendations for this section, and very briefly, I'd like to stress that adult patients should be assessed for problems that could arise from sexual activity, and that multi-pronged psychosocial approach is needed in patients with hemophilia and sexual dysfunctions, and hemophilia treatment centers should provide the patient with such service. The next big section in chapter 9 is surgery and invasive procedures. Of course, treatment with CFCs or clotting factor concentrates or other hemostatic agents should be considered before invasive diagnostic procedures such as lumbar puncture, arterial blood gas determination, or an endoscopy with biopsy, just to avoid any bleeding complications during or post intervention. DDAVP can be used as hemostatic treatment for surgery and other invasive procedures in patients with mild hemophilia A. Of course, the problem with DDAVP is that the phenomenon of tachyphylaxis. So over the course of therapy, the effect of DDAVP is decreasing. And if the patient with mild hemophilia A requires longer treatment, then we have to switch from DDAVP to replacement therapy, so to infusions of clotting factor concentrates. If clotting factor concentrates or bypassing agents are not available, adequate blood bank support for plasma components is needed, because, of course, we all know that in many patients in the world, unfortunately, do not have access to clotting factor concentrates. Of course, with respect to bypassing agents, it's the agents that are used in patients with high responding inhibitors, of course, to replace them with plasma components is, frankly speaking, impossible. But in patients without inhibitors, of course, fresh frozen plasma or cryoprecipitate can be used if clotting factor concentrates are not available. 2 recommendations for surgery section. During surgery, sufficient clotting factor concentrate must be available. So if we plan surgery, if we are to perform surgery in patients with hemophilia, we have to make sure that we have sufficient amount of clotting factor concentrates to perform surgery and provide patient with adequate hemostatic therapy. And I'd like to stress again that desmopressin should be used pre-surgery in mild hemophilia A patients. Why so? Because in patients with mild hemophilia, in contrast to patients with severe hemophilia A, the risk of inhibitor development is increasing with the number of exposure days. So if we decrease the number of exposure days to factor 8 concentrates, then we may decrease the risk of inhibitor development. That is a very important hint. With respect to neuroaxial anesthesia, we generally advise against neuroaxial anesthesia in patients with hemophilia. Why so? Because there is a risk of bleeding complications, but in fact, it is not absolutely contraindicated, because patients who has corrected defect of hemostasis, in theory, can receive this type of anesthesia. Nevertheless, we suggest rather to use general anesthesia instead of neuraxial anesthesia. And a very important suggestion and recommendation with respect to intensive treatment of patients with hemophilia B, so patients undergoing surgery, for instance. We suggest to avoid use of prothrombin complex concentrates. Prothrombin complex concentrates contain not only factor 9, but also factor 2, factor 7, and factor 10. And in patients with hemophilia B, with deficiency of factor 9, but with normal levels of factor 2, 7, and 10, the intensive infusions of PCCs may lead to accumulation of factor 2, 7, 10, and, at least in theory, the higher risk of thrombotic complications. So we definitely prefer to use pure factor 9 concentrates. In our section on surgery, we have this important table with the definition of adequacy of hemostasis for surgical procedures. Of course, there is no time to go into details of this table, but as you see, we have 4 categories: excellent, good, fair, and poor or none. And to make the long story very short, we have to assess or evaluate the blood loss during and after surgery. We have to evaluate whether extra doses of factor 8 or 9 or bypassing agents were needed. And we have to evaluate the volume of blood that had to be transfused in the perioperative period. Of course, some major surgical procedures put the patient at risk of blood loss, and even with perfect hemostatic activity of deficient clotting factor, thanks to replacement therapy, we may observe blood loss that requires blood transfusion, for instance, major orthopedic surgical procedures. Another section in our chapter number 9, is the section on psychosocial issues. Of course, severe hemophilia is associated with major psychological and economic burdens for people with hemophilia and the caregivers. On this slide, you see the key functions of social worker working at the Hemophilia Treatment Center. Again, there is no time to discuss all these functions, but I encourage you to read this section in our chapter. However, I'd like to show you the 3 recommendations on psychosocial issues in patients with hemophilia. So psychological and social support needs to be part of comprehensive hemophilia care. Patients and families should join support groups. And finally, assessment of the development of patients with hemophilia progression and prevention of comorbidities and functional impairments is recommended. The last 2 sections, very big sections in our chapter, are comorbidities and aging. Of course, the list of comorbidities and also problems associated with aging of patients with hemophilia is very long. I will present our recommendations, suggestions, comments on this slide and several more slides. I would like to start with cancer malignancy. Maybe before I talk about cancer and malignancy, I'd like to stress that the patient with hemophilia simply live longer than it was a couple of decades ago. And this is because of advancements in hemophilia therapy, hemophilia management. We have better access to hemophilia therapy, and patients fortunately do not die because of bleeds. However, because of that, they develop diseases that were not observed 3, 4, or 5 decades ago, like, for instance, cancer malignancy, but also many others, which I will mention in a moment. So here we see cancer malignancy. What I would like to highlight: patients with malignancy, of course, they should be treated for malignancy as patient in the general population. However, chemotherapy is very often complicated, among others, by long-lasting thrombocytopenia. And this is, of course, very dangerous for patients with hemophilia because the risk of bleeding complication is even higher than because of hemophilia. So we should consider continuous prophylactic replacement therapy for severe long-lasting thrombocytopenia. This is very important. The second thing that I would like to highlight is the risk of venous thromboembolism of patients suffering from malignancy. We all know that malignancy increases the risk of venous thromboembolism, but in patients with hemophilia, use of anticoagulants is always a big question mark because we have to balance the benefits and risk associated with such therapy. Use of anticoagulants is not contraindicated in patients with hemophilia if the risk of venous thromboembolism or the patient just developed venous thromboembolism, then of course we should consider use of anticoagulants. And if the benefit from the use of anticoagulants is higher than risk of bleeding, then of course we should do that. We would like also to stress that patients with hemophilia are prone to hemorrhagic stroke. Atrial fibrillation is another big challenge for this patient population, I mean patient with hemophilia. Why so? Because normally the patients without hemophilia are treated very often with anticoagulants. But in patients with hemophilia, we have to evaluate, we have to assess the risk of bleeding complications and risk of stroke. If the risk of stroke is high, then of course we should consider use of anticoagulants. But again, first we have to correct the defect of hemostasis. Without adequate replacement therapy, we shouldn't use anticoagulants in patients with hemophilia. Of course, there are differences between severities of hemophilia. In patients with mild hemophilia, we can do that. But in patients with severe hemophilia, we shouldn't do that. Of course, the details you will find in the text of this section. Patients with inhibitors should not be treated with antithrombotic therapy. This is the general statement. But of course, one can find in the literature the reports on use of anticoagulants in patients with hemophilia complicated by high titer inhibitor. The problem with patients receiving bypassing agents is that it is very hard to predict the response to bypassing agents. So we are not sure whether the patient is protected in a sufficient way against bleeding complications. So anticoagulation can be used in inhibitor patients only in exceptional circumstances when the risk of thrombosis is very high, is much higher than risk of bleeding complications. With respect to venous thromboembolism and thrombosis in general, I will repeat again the same. We should balance the risk of bleeding and risk of thrombosis. Patients with hemophilia are protected, at least to some extent, against venous thromboembolism. However, some risk factors for venous thromboembolism may be present in a patient undergoing surgery. For instance, a patient with hemophilia undergoing major orthopedic surgery with some additional risk factors for VTE, like obesity, like immobility, or patient undergoing major abdominal surgery for cancer. The risk of VTE can be really high in those patients. And we can use anticoagulants for those patients, but we have to make sure that the defect of hemostasis has been corrected in most cases with replacement therapy. Of course, patients without inhibitors can achieve anticoagulant therapy after hemostatic control. In contrast, patients with inhibitors, high titer inhibitors, have rather contraindications to use of anticoagulants. However, in some cases, again, it must be used. I mean, anticoagulants must be used, but then we have to use bypassing agents, and we have to make sure that the patient is protected against severe bleeding complications. We still don't know enough about combination of emicizumab and anticoagulants in patients with hemophilia A complicated by high titer inhibitors. With respect to metabolic syndrome, of course, overweight patients with hemophilia need dietary advice similarly to patients in general population. An interesting aspect of overweight is the replacement therapy in patients with hemophilia A and B. So overweight patients should have factor 8 or 9 replacement therapy based on lean body weight and not actual body weight. With regard to diabetes mellitus, of course, it should be treated the same way as in the general population, and subcutaneous insulin injections are not contraindicated and can be performed in patients with hemophilia. We also discussed renal disease and osteoporosis in patients with hemophilia. We have not produced any recommendations with respect to these two problems. However, I'd like to stress that in those patients with hemophilia who require renal replacement therapy, the choice between peritoneal dialysis and hemodialysis depends on patient-specific factors. And of course, the decision should be taken together with nephrologists. With respect to osteoporosis, of course, we should use patients with hemophilia are at higher risk of osteopenia and osteoporosis, and we should use adequate pharmacotherapy for those patients. With respect to the degenerative joint disease, we recommend that all patients have regular physical activity. This is very important recommendation. I already mentioned osteoporosis, so anti-osteoporotic medication is required in case of osteoporosis or osteopenia. Hypertension, arterial hypertension is also a very interesting issue because there were some papers on higher incidence of arterial hypertension in patients with hemophilia as compared with men of the general population. So we definitely recommend regular blood pressure measurements, and the management of arterial hypertension should be the same as for males of the general population. Coronary artery disease is again a huge challenge for patients and for treaters. And we have the same challenge which I already discussed with respect to Venustrambolism or arterial fibrillation. We have to use antithrombotics, and we use antithrombotics in patients without inherited bleeding disorders, but also in patients with hemophilia. If we treat coronary artery disease, we have to consider use of antithrombotics, and they can be used provided the patient has corrected defect of hemostasis. So anticoagulants can be used, but the decision must be very cautious, because if the risk of bleeding complication is higher than the benefit of anticoagulation or antithrombotic use, then of course we should give up with this idea. Hypercholesterolemia treatment is as in general population, and with respect to psychosocial issues with aging, of course, aging patients need active psychosocial assessment and support. So this is the end of my presentation. We went through many topics addressed in chapter 9, but of course it was simply impossible to discuss everything. And even those topics that I discussed over the last 30 minutes, many aspects or information on those topics were not addressed during the presentation because of lack of time. Therefore, I definitely encourage you to read the whole chapter. But I would like to end my presentation with this slide, the outstanding questions. Probably the number of questions that still wait for answer is much longer, but let me show and let me read these 5 questions. First, more research is definitely needed to better understand the safety of antithrombotic therapy in patients with hemophilia A complicated by factor VIII inhibitors who are treated with emicizumab. The advent of emicizumab is a fantastic story for patients with hemophilia A complicated by inhibitor. Nevertheless, we have to learn a lot about, among others, use of anticoagulants in patients on emicizumab. There is currently a lack of evidence-based consensus on how to manage VT in patients with hemophilia. For instance, what should be the plasma levels of the deficient clotting factor during anticoagulation. Little is known about the prevalence of diabetes mellitus in people with hemophilia. More research on this topic is required. While secondary prophylaxis reduces the incidence of bleeding, its efficacy in improving orthopedic function has not been clearly established. Finally, the causes of the increased prevalence of hypertension in patients with hemophilia remain unclear. And also with respect to this very important issue, we need more evidence, we need more research. So with that, I'd like to thank you for your attention. Thanks to Hemophilia Alliance for their support in developing this presentation. And of course, I'd like to thank all co-authors of Chapter 9 of the WFH Guidelines for Hemophilia. Thank you very much.